You are going to start now?
We are about to be live now. With all your due permission, we are beginning with the session for today. A very good evening to all. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned urologist, Dr. Mahesh Desai, sir. Sir is MBBS, MS, FRCS from London, FRCS from Edinburgh, Head of Robotic Surgery and Medical Director at Mulji Patel Urological Hospital, Nadiad. With Sir's wonderful insights, we are going to talk about the topic for today as we are witnessing the Prostate Cancer Awareness Month. So, the topic for today's discussion is prostate cancer screening. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So, over to you. Please proceed.
Thank you, Batul. And it is indeed a pleasure to be here. And I'm really grateful to the IGCP for inviting me to give this talk. Um, uh, I'm going to talk about the prostate cancer screening. And the screening for the prostate cancer is very, very important because we have to do an early diagnosis. Early diagnosis is essential for the proper treatment and aim to cure with a minimal morbidity. 70-year-old man with a metastatic prostate was once a 50-year man with a localized curable disease, what Patrick Wall said in 1995. Why is that? Is because the prostate cancer in America at that time, I mean, still, it is the number one cancer in as far as the incidence is concerned, and the second as a mortality. Worldwide, it is third on incidence and seventh on mortality. What about India? In India, in 1990, cancer prostate ranked 11th most common cancer among the Indian males. And age-adjusted incident rate was 2.5 per 100,000 male population annually. The recent data from a National Cancer Registry program indicates a significant escalation. Cancer prostate ascend to third most common cancer among the Indian males by year 2022. An estimated incidence rate is a 6.8 per 100,000, and a cumulative risk is 1 in 125 men. And the burden of the prostate cancer in India is expected to rise further due to population growth, increasing life expectancy, and an increase in the proportion of the aging male in the country. Um, and that is the most important. And here, at this moment, there are 50% of the population is below the age of 25 years, and more than 65 is below the age of 35 years. Expected in 2020, average age of an Indian will be 29 years compared to 37 years for the Chinese and 40 years for the Japanese. 9.8 crore males are over 50 years of age. That is the age which is for a prostate cancer is possible to develop. The average life expectancy has increased to 70 years. All this demographic data will have a bearing on the changing incidence and the pattern of the prostate cancer in ensuing the decade. Now, what is most important, if you look at the urban population and the rural population, there is a different incidence. The cumulative risk of getting prostate cancer was 1 in 42 males for Delhi, followed by 1 in 47 males in Kamrup urban. In contrast, the risk of low in West Arunachal rural area with cumulative risk of 1 in 462 per males. And if you see all the cancer which occurs, the prostate cancer starts around 50 years and then it reaches the highest. And here, the age specific rate for the prostate cancer started to rise after the age of 50 and increase further as age increases. In India, all the incidence and mortality rates for the prostate cancer are relatively lower compared to the Western and the European countries. The ratio of mortality to incidence rate is higher. Remember this, ratio of mortality to incidence rate is higher. The prostate cancer in India is diagnosed mainly in its advanced stage, notably a higher proportion of a distant metastasis. 42.9% were found in patient in India compared to USA only 8% and Norway 8.9%. And then we are ignorant regarding our disease and our chance of getting. And the prostate cancer is a very slow growing. Doubling time is 2 years. Though that's why the screening and early diagnosis is very, very important, because the CA prostate incidence is increasing among all the age group, indicating emerging public health problem exacerbated by the aging population, increased life expectancy, and expanding urbanization. People are moving to the urban area from the rural area. The new estimate offers a valuable insight for the cancer prevention and control activities through the intervention of early detection, risk reduction, and a management of the cancer prostate in India. It is important that the cancer prostate burden focusing on identification of affordable and accurate diagnosis and management option in Indian population. This is what I'm going to speak today. When we started our hospital in 1978, we diagnosed cancer by only digital rectal examination as a palpable nodule. We did a blood test, serum acid phosphatase, and then we did a digital guided biopsy of palpable nodule. And what was the treatment? Only bilateral orchidectomy and stilbestrol. And there was no staging, there was no grading, and nothing, only one treatment. And that's how they. But then we improved. In 1985, we got ultrasound, and ultrasound is a part of the clinical examination, and prostate evaluation was done, especially to do the benign condition and a malignant condition. And that's how we are going to see the use of the ultrasound is much more. So here, if the cancer is palpable cancer on a digital rectal examination, then in 82%, it is a hypoechoic area. This is a hypoechoic area. If it is a non-palpable cancer, it is a 35% is a isoechoic. This is a isoechoic. But you can see here is a peripheral zone, but here is the area which is isoechoic, but this is a shows a little asymmetry. And the tumor size, if less than 1 centimeter, only 19% are visualized. And then if you suspect, then you would to do a biopsy, and you can do a biopsy transrectally or a transperineally and take a core to find out whether is cancer is there or not. And then the different type of probes are available, slowly become available. This is a side firing probe, this is the end firing probe, and this is a biplanar probe. So you can take the biopsy from exactly the position. You want to take a biopsy from here, you can take a biopsy from exactly that position, and then you'll have a diagnosis. And then you have a pathologist will give you the Gleason score 4 and 5, 9, and it is a high grade cancer. And then how much is cancer occupying the your specimen, that will also be very important. But what is most important was Thomas Stemming in 1987 from Stanford. He discovered PSA, prostate specific antigen, and that it is the one was a tumor marker. And that changed the whole scenario. But we adopted at MPUH in 1989, 2 years after it was invented. And then if you see the prostate cancer mortality, which started, you can see that after 1988, the mortality came down. And that becomes important. So PSA is the first important for the screening of the prostate cancer. Clinical should use a PSA as a first screening test. This is a strong recommendation. Evidence level is grade 1. And the PSA is liberated in the blood because the basal cell, which is destroyed in the cancer, and that comes out. And there are total PSA, free PSA, complex PSA, the very thing. But PSA is important in diagnosing, staging, treatment point of view, follow-up, and most important, the screening of the prostate cancer. That's what we're going to talk. But then we found that there is a variation in the races. We Indians are different, and we did a study, and we found the age-specific prostatic antigen, that is the PSA, is compared to the America or Japan. It was a 2.5 in America between 40 and 49, while in India it was 2.1. In 50 to 50, in between 50 and 59 age, it was 3.5. In India, it was 3.4, and in Japan, it was 3. And if you there 70 to 79, it was 6.5 in America, while here in India, it was 5, and in Japan, it was 5. And this was very, very important. And then most important was the PSA density, depending upon the volume. And in India, the volume of the prostate is smaller. And then that's why our cutoff value of this thing was 0.15 at the age of 40 to 49. So this is a suspect. When you have a PSA density of 0.15, you can suspect cancer, and then you can go ahead with a various investigation like a digital rectal examination, transrectal sonography, and a MRI. So guideline was for people with a newly elevated PSA, clinician should repeat PSA prior to the second biomarker imaging or biopsy, because one PSA may be wrong. So you do the second PSA, if it is, especially if it is elevated, and then the second PSA after about 3-4 weeks, if it comes same, then you go ahead. But very often, nearly 40 to 50% time, the PSA will drop down. So combined with digital rectal examination, the PSA, and a transrectal sonography of the prostate, your sensitivity of picking up cancer becomes increased. And then we started to do the camps because we wanted to know how much the cancer in our community, because most of the time the cancer comes with a very advanced when nothing much can be done, when we wanted to have the cancer in early stage. So first thing, we get the people in a camp by this advertisement, and then we explain to them, okay, this is the prostate, and the prostate has got a benign gland and a cancer gland, and these are the symptoms, and then these are the tests where how you can do it. I'll do the PowerPoint presentation, and then educate the people. You put up the posters and boarding handbills, and then we have printed a book and in Gujarati, and then given it to the patient so that what is most important is awareness that we can develop prostate cancer, and only way to know is doing a PSA and the examination, and then you can detect and you can cure it, because surgery now is possible because of the open or a laparoscopy or a robotic surgery. And here is a full information which has been given. Then we do those people who attend our camp, we do the full registration because we want to study our own patient. Then we take a consent that what we are going to do. Then this is a form which is a IPS, that is an International Prostate Symptom Score, and they fill up themselves, and then we judge. Then we do the uroflowmetry, where they pass urine machine, and then you see the graph, and then you can make out whether patient has got any symptoms of obstruction or is normal. Then we do the blood pressure, the height and weight. This is very important. We do the blood collection, especially the kidney function, the nomogram, and the PSA. PSA is the most important. And then after that, we study whole program. We divide the patient into 3 groups, where the PSA is less than 1, PSA is between 1 and 2, and then PSA is more than 2. And then second visit, we invite them to the hospital. Here again, we explain to them why they are called a hospital, because the instruments are there, the ultrasound is there, MRI is there, and you can get this test is done, and then we can do, if positive, we can do a biopsy, and then we can give a treatment. Everything will be free. Now here is the patient who has been explained and he's been examined, and then we do the transrectal sonography, which is and then a physical examination and the uroflowmetry. Now we got a better ultrasound. This is the micro ultrasound, and which is 29 megahertz and 300 times more vision. It's a better imaging and better patient care, reduces the false negative, faster detection, real-time targeting, suspicious region over the time, much better ultrasound. Then we do the transrectal sonography. And here we can divide, this is the Primus 1, which is the benign condition. Primus 2 is a benign. Primus 3 is maybe cancer, maybe benign, but we have to further test it. Primus 4 is, this is you can see, this is the cancer. And this is a hypoechoic area, this is a hyperechoic area, this is a starry sky, and this is a hypo. And this is like, you have a picture like a cauliflower. This is the Primus 4 vision, and this is the Primus 5, where you have a hypoechoic area like a shadow. And then in this case, we do the thing. We do the Primus, we look at the different part of the prostate and then find out. And after doing and then making sure or suspecting, we do the MRI. Because MRI will give you, there is a multi-parametric MRI, which will give you the idea if there is a presence of cancer. This is a very sensitive test, MP-MRI. And we do, and then it gives you the idea where the cancer is, and then these are the places where there could be a cancer. Then we can take a biopsy. Now, for example, this is a male, 60 years. His PSA is raised and his family history is positive. He's got a nodule, hard nodule. His PSA, if you see, is more. And then he is a transrectal sonography shows a hypoechoic area. This is the lesion, and then you can take a biopsy of that area, and then it will give you this is the biopsies taken, and this is shows the Gleason pattern 3. This is the cancer. This is again a cancer. You can see the biopsies taken, and now this is a fusion biopsy with the MRI and ultrasound, and then you can do that. This is another patient with a PSA 3.5, and he's got a very small hypoechoic area, very early. Nowadays, we can do the targeted therapy where we can destroy that area and we don't have to do the surgery. But we have done an MRI, and then we have done, this is a hypoechoic area, and this is a fusion with MRI, and then we have taken a biopsy, and a biopsy shows the result which is there. Now, we have done about 676 patients, and this is the age group. You can see from 50, 51 to 60. And here we found a suspicious area in 33 cases, 5.4%. And we found a positive cancer in 10, it is 1.6. And here the comorbidity was 42%, no comorbidity in 57%. And here the positive family history of cancer was in 1.2% cases, 7 cases, father 6, father and brother in 1. But then associated family history like a breast cancer in female in the same house can also suspect you can have the prostate cancer. And when there is a suspicious, then you must do the full investigation, ultrasound, MRI, and the biopsy. Then you do a digital rectal examination, and here with if the PSA is high, you do the digital rectal. You might see asymmetric gland, palpable hard nodule, firm or hard. Then you can suspect, go ahead with ultrasound, MRI, and then if necessary, you can take a biopsy. 85% in our cases, we found there was no symptoms, while in 15%, there was a urinary symptoms of power difficulty. If we did a transrectal sonography, in 10%, we found a hypoechoic area, which is suspicious of malignancy, asymmetric gland in 11% of cases, and then we go ahead and take a biopsy. There are the other parameters. What is most important is if the patient has got the 53% patient had a PSA 1, less than 1. Here we will observe them for 3 years, 5 years. We do the re-checkup for up to the age of 65. But still, if it doesn't increase, then we don't do any more checkup. Similarly, if it is up to 2 in 75% of our cases, we go on checking up every 3-5 years up to 70 years. And after that, if it does not increase, then we stop. 25% of the total participant in the screening camp has a PSA above 2. Now, this patient will require to be followed up. And that's we followed up 3 to 5 years, and then we followed up to 70, 75 age. But here, the 5% total participant in screening camp had a PSA above 6.5. He undergoes full checkup, including ultrasound and MRI and the biopsy, because here chances of cancer is more. And here we found that 349 was normal, BPH was 193, and cancer of the prostate was in 29 cases. Now, this is the age group wise statistic. Age increases, the IPS score increases, prostate volume increases, PSA also increases. But if PSA is 3 or 2.8, we have to undergo, and this is density. This is the area where we have to do the full investigation to find out. And here, when when the PSA is more, this is the area which we have fully investigated for the cancer. And then we found, and I just go little faster here. And here we did a suspicious on a micro ultrasound. We found 33 cases out of 603 cases suspicious for cancer. And out of that, we found 10 cases which was positive for cancer. And all out of this 10, 7 patients underwent a radical prostatectomy. 3 patients were advanced cancer. He went for a medical treatment. At the same time, same here, we do the MRI along with this. And here the 10 patients who are positive. And then you have the grade is 3+3 is early, 3+4 is early, but 4+3 and 4+4 and the PNI and IDC and LVI, they all are a little advanced cancer or aggressive cancer, which you have to do it. So in patient undergoing repeat biopsy, no prior prostate MRI is done. You must do the MRI before you do the biopsy. Otherwise, you can do the fusion biopsy combining ultrasound with MRI, or you do a transrectal or a transperineal biopsy, or you can do, but whenever you see a target, you must do a 2-needle biopsy. Then you will be able to detect. And here we found that in 6 cases, we found there was no change in our grade, but 33% had upgraded and 16% has a downgraded. This is after the surgery, the histopathology. And this is very, very important. Now, what is most important is we have done 1,000 radical prostatectomy, and then we have compared with the screening with already done. And we found that 93% of the patient had above PSA density is very important, 0.10, while 80% of participants in screening camp have a PSA density below 0.10. 86.5% patients have above PSO density of 0.15, while 10% participant or screening camp had a PSA density more than 0.15, and they all had a cancer. So this is our team which goes and examines the patient, and they do all the analysis. And these are the machines which we have. The Nitiraj is a biostatistician. He do all the analysis, and the Kalpesh Desai is our technical support for this. Thank you very much for listening. If there's any question or problem, you please write to us. We will give you the answer. If there's any question, I will happy to answer.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on this awareness. We are witnessing the Prostate Careness Awareness Month, and in this month, the topic that we have shared and the topic that we have discussed was really important for our viewers to understand and to spread awareness about the topic. So thank you so much for doing it with your enlightful PPT presentation that you have shared with all your experience. The way you have presented your PPT is remarkable. So thank you so much for doing it, sir, with your valuable time and providing it here at our platform. Moving ahead with the question and answers, we have
Yeah.
received a question from our viewer. So would like to put it across. The question is that would patients diagnosed with prostate cancer see a cancer specialist or a urologist? Whom to consult first?
For the prostate, I think the urologist, because we are trained. When we do the digital exam, we can suspicious, and then we are can do a transrectal sonography, which we do it, and then we do the biopsy. Only MRI, we send it to the radiologist and then we see the report. And but there is a machine where you can do the fusion. So the urologist is well trained. You saw all the team, my team, they were all students of DNB, and they all are taught the way to do a digital rectal examination, transrectal sonography, and the biopsy, and how to read the MRI. And they do the surgery also. They do laparoscopic radical prostatectomy or a robotic radical prostatectomy. So under the one roof, under the one surgeon, and then he goes on following up the patient over the years, and that is most important.
Thank you so much, sir. Thank you for answering that question. With that question, there's a follow-up question related to that. And the question is, if suppose one goes on and consults a urologist, like you said, it's under one roof. So is it necessary to consult a cancer specialist, or rather, when is the time when one has to go for a cancer specialist? Is there any such time when a urologist may refer to a cancer specialist? That might be a case. So if you can have light on that.
Okay, cancer specialist may be surgeon. Now he may be specialized in head and neck, or say chest surgery or abdominal. And like we urologists, we are looking after the cancer of kidney, cancer of ureter, cancer of bladder, cancer of prostate, cancer of testicle, cancer of penis. And we are doing all the disease of that. But then you have a onco physician. Now we take a help of onco physician. He is on our team, because suppose prostate cancer is advanced and it requires a treatment, the medical treatment or chemotherapy, then we take the help of them. Then patient needs a radiation, then we take the onco radiotherapist, who is expert. So it's a teamwork. So, but basic person who starts is a urologist, and then we have a team. We have an onco board, and in that onco board we have a onco physician, the radiologist, and suppose there is a disease of the kidney which is involved intestine also. Then we take a help of GI oncologist as well while we are doing the surgery. Or there is a thrombus which is going into the IVC or a chest. We must sometime we take the help of the vascular surgeon also, who is encouraged. So it is up to the surgeon, urologist, to decide whom to invite depending upon the progression of the cancer.
Thank you so much, sir. Thank you for answering that question. Already, we have covered about the screening part in our talk as how to do the screening for prostate cancer. But then again, how often do we need to do the screening for prostate cancer? And once the cancer is cured, is there any other chance that the person might be at risk, or maybe in their generation, the upcoming generation may be at risk of prostate cancer? If you can have light on that, sir.
Excellent question. I think it is very, very important, because of cancer, when it happens, it is likely that it might. Now, if you have a cancer and then you have a diagnosed, you have examined and there is no cancer, all right? But still, there was a suspicious. So after 3 years, 5 years, we repeat PSA, we do the repeat test. Because prostate cancer, as you see, starts from 50, it can from 50, and then it goes up to 70, 80. After 80, we may not be treating the cancer, because the patient has there are medicines available. There are which patient life can be prolonged. It's very slow growing cancer. Doubling time is 2 years. I mean, it is a 1 millimeter today. It takes 2 years to become 2 millimeters. Then 2 years to become 4 millimeters. So But when after treatment, you have to follow that up. Suppose if you have done surgery successfully and your PSA is not detected, so you may do 3 years, 5 years, say maybe 10 years. But once you should keep an eye because cancer is very deceptive and you need to keep yourself following up. The chances of recurrence is very, very less, but you need to follow yourself.
Thank you so much, sir. Thank you for putting across this particular point of view in front of our viewers and for making them understand about the topic in such a better manner. This was the last question for today's session. And at the outset, I would definitely like to thank all our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And also, I would like to thank you, sir. It was really an honor to hear you out on our platform, to be a part of it with you, sharing the same platform was really an honor. So thank you so much, sir, for giving us that space and for giving us that opportunity. And also, I would like to thank you for your valuable time and for the contribution that you have made in making our viewers aware about it. So thank you so much, sir.
Thank you, Batul.
Thank you. And before we conclude, sir, any last take-home message from your end?
Well, I think health is a very important, and I think we are there to help, but you should be aware of it. Now there are enough information available on a YouTube or on IV on a thing. You should look at it regarding the prostate and the cancer, how to detect it, and what are the reasons for every cancer, even a kidney cancer and then bladder cancer. You should do it, and you know what causes the cancer, like smoking, tobacco, and you should avoid that, so cancer awareness is important for first step to early diagnosis and treatment.
Thank you so much, sir. Thank you for your remarkable take-home message. And with such a valuable message, we would like to conclude our talk here for today. Until next time, I would request our viewers to stay tuned with us for the further upcoming episodes and sessions on our platforms. Thank you so much, sir.
Thank you.